Presenting today on diabetic fibrillosis, a case report of a microscopic dilemma. We will first start with an introduction, some background on the case, speak on the case presentation, pathology findings in the case, and then discuss the main learning points of the case. Nephrotic syndrome is characterized by damage to the glomerular basement membrane, leading to hypoalbuminemia, proteinuria, edema, and hyperlipidemia. Under the umbrella of nephrotic syndrome includes diabetic nephropathy, which is a complication of both type 1 and type 2 diabetes mellitus that can lead to end-stage renal disease. First described in 1970 was diabetic fibrillosis, an electronic microscopic finding of diabetic nephropathy of nonspecific mesangial fibrils found in multiple organs indicating systemic disease in a post-mortem evaluation. There is limited research primarily in the form of case reports, which includes possible poorer prognosis for patients with diabetic fibrillosis found on EM. The EM fibrils are easily misdiagnosed as fibrillary glomerulonephritis, as well as needing to be distinguished from other diseases such as amyloidosis. The case we present is of a 69-year-old female with a past medical history of poorly controlled hypertension and left-sided CVA that presented with worsening shortness of breath and fatigue, admitted for hypertension emergency, and evaluation of AKI with an unknown baseline. Vital signs showed severely elevated blood pressure to 190 over 157 and tachycardia to 102. On physical exam, there were diminished breath sounds in both lung bases and 1 plus pitting of edema of the bilateral lower extremities to the knee. Creatinine at presentation was 3.6 milligrams per deciliter. Potassium was 4.7 millimoles per liter. Bicarbonate was 14 millimoles per liter. Hemoglobin A1C was found to be 6.5%, and albumin was mildly low to 3.3 grams per deciliter. Patient also had adequate urine output throughout her hospitalization. Urinalysis was significant for proteinuria as well as microscopic hematuria. Further workup showed an ANA that resulted with 1 to 320 titer with homogeneous pattern. C3 and C4 were within normal limits. The patient was started on loop diuretics, as well as an angiotensin receptor blocker later in her hospitalization, and discharged as well with a calcium channel blocker. Prior to her discharge, a renal biopsy was performed. The patient was also started on an insulin regimen. Her creatinine improved to 2.6 milligrams per deciliter, and she was able to follow on an outpatient basis with nephrology following her hospitalization. Initially, the patient's pathology report indicated fibrillary glomerulopathy. However, final renal biopsy results were significant for diabetic nephropathy, characterized by diabetic fibrillosis, allowing treatment to be focused on prevention of progression of diabetic nephropathy, and the patient not needing to be inappropriately treated with unwarranted agents such as steroids. In the middle of the poster, Figure 1 demonstrates the findings of the left native kidney biopsy. On the left, images A and B are of hematoxylin and eosin stains, showing sclerotic glomeruli with thickened glomerular basement membrane, plasma incidation, interstitial fibrosis, tubular atrophy, and chronic interstitial inflammation. On the right, image C demonstrates the electronic microscopic findings of thickened GBM, mesangial sclerosis, and fibril deposition. Fibrils seen range in diameters between 12.4 to 16.2 nanometers. Included in the case is a discussion section where we will discuss major learning points for the case. The case emphasized the importance of considering diabetic fibrillosis when fibrils are seen on electronic microscopy versus other conditions, such as glomerulonephritis or amyloidosis, that would require more intense treatments. It is also crucial to promptly identify the underlying causes of renal disease to prevent its further progression, such as to ESRD, which a patient could potentially require dialysis. Additionally, conducting further studies for more comprehensive characterization of fibrils is essential to enhance the diagnostic capabilities for glomerulonephritis. Thank you all for listening. This concludes my presentation.